Meredith, I can't believe this is finally happening, but I have a pun for you.
Oh my God.
And it fell into my lap, courtesy of my cousin's dental practice.
Excellent.
Meredith, who is a dentist's favorite rapper?
I don't know, Monee.
Flow Ride?
The pause was perfect. That was solid.
Thank you.
I have one too.
Oh, God.
Okay. So Max is now of the age where he loves playing hide and seek.
Okay.
And I was just telling him how great it is that I'm a hospitalist and not an intensivist, because otherwise he would be finding me in the ICU.
This might be on par with oncologist.
It's pretty solid, I know.
Throwback to the Onc Emergencies episode.
The Curbsiders podcast is for entertainment, education, and information purposes only, and the topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions. Furthermore, the views and statements expressed on this podcast are solely those of the host and should not be interpreted to reflect official policy or position of any entity, aside from possibly Cashback Memorial Hospital and its affiliate outreach programs, if indeed there are any. In fact, there are none. Pretty much, we aren't responsible if you screw up. You should always do your own homework and let us know when we're wrong.
And welcome back to Curbsiders. I'm Dr. Monee Meredith, joined by my eternally effervescent co-host, Dr. Meredith Trubitt, as well as the rest of our hospital medicine team, frankly, Dr. RJ Blackburn and Dr. Caroline Coleman. Guys, I think this is the first time we've all been together on the mic at the same time. It's great. Anyway, there's a reason we have our full crew today. It's a new thing for us. It's very exciting. We're doing a recap of our favorite hospital medicine episodes. But before we embark on this sure-to-be thrilling journey, Meredith, will you please remind the good people in the audience what it is we do on this show?
Sure, Monee. We are the internal medicine podcast. We use expert interviews to bring you clinical pearls and practice-changing knowledge. However, tonight, as you can already tell and as you already mentioned, this is a little bit different. We're just doing our highlights of pearls from the last year and change.
Fantastic. Before we get to the pearls, though, picks of the year, I think, are kind of important. We need to reflect on the things that made the year amazing. So, RJ, will you kick us off with your pick of the year?
Absolutely. So my wife and I have been into a show on Hulu, so Only Murders in the Building. This is usually not something that I really like, but really gotten into it with the characters and the dialogue and kind of the mystery with it. Just really, really loving it right now. So I'm sad that this season's over and I have to wait for next. So
that trio, that odd trio of Steve Martin, Martin Short, and Selena Gomez, for those of you that don't watch, whoever thought of that? Brilliant, frankly. Caroline, what's your pick of the year?
My pick seems broad, but is going to be women's sports because, of course, women have always been exceptional athletes. And we all had a ton of fun watching the Olympics with Suni Lee and Simone Biles, Lena Meyer, like Katie Ledecky. It just, the list goes on. But I think what's been cool about 2024 is that folks have really been investing in women's sports in a way that lets us all watch it ubiquitously. And I think it's just been the year that everyone watches women's sports, and that's been cool to watch.
Yeah, I was telling Caroline this last night when we were at dinner together. But I was watching a men's basketball game and they were just talking about the women's basketball. And I was like, we have arrived.
And well deservedly, the talent's there. But yeah, we've got the talk equity now, which is pretty cool.
Yeah.
Yeah. I mean, when they're talking segments on First Take and things about women's sports, that's when you know things are happening. And Bill Simmons is talking about her. Anyway, Meredith, what's your pick of the year?
I have two. My first is Monee and I went to something corporate concert in September, and it was like my teenage self come alive. It was so great, and it was definitely a highlight of the year. But the other highlight I have to say is that for those of you who don't know Snoop Dogg, you know Snoop Dogg, but like he has really come in, you know, Caroline's mentioning the Olympics. He's like come into this whole new stage of his life, including that he makes children's like music. And I just respect this man so much. Like, look at his career trajectory. It is one of the most fascinating things I have ever seen. And so I just think that's my other pick of the year. Snoop Dogg, Doggyland. for the kids out there.
Affirmation song.
For sure. For the adults out there who are having a bad day at work.
It really is. And I feel like this next stage started with his cameo at the Super Bowl halftime show a few years ago. I think that's where it all kind of started, where he was just kind of dancing in his own brain, which is kind of Snoop at baseline. But yeah, I feel like that's where it started. Okay, so I can't believe that it took my med student who's on service leave right now to remind me what my pick of the year was. But it is a Michigan college football sandwich. The Michigan college football team won the national championship at the very beginning of 2024. And they have closed out this year by winning the quite possibly worst football game I have ever watched against the Ohio State University. And we beat them, and it was fantastic. And we were 21-point underdogs. Okay. And then I do need a second pick of the year because it's me, and I had to get Kelly Clarkson in there. She has a cover from her TV show of My Heart Will Go On by Celine Dion that I have probably watched by myself 50 times. It is incredible. And that's all I have to say about that.
That'll be the only thing we link in the show notes.
It's really good. Okay. I don't think you understand. Ordinarily, I would say you should not be covering Celine Dion. However, stupendous. Okay. I think that probably means we need to get some pearls. So, RJ, can you kick us off with some nuggets from your very first episode you produced with us? It was the diabetic foot infections episode with Dr. Andrew Webster. I did the graphics, and like I said, you did the producing. So what kind of stuck out to you and reflecting on that episode?
Absolutely. I mean, obviously I'm a little biased. I think it's a great episode, but, really several things. One of the things that I enjoyed the most was the way that Dr. Webster frames his conversations with patients about diabetic foot infections. He kind of gave like a 4-step approach. Well, I'll use the word step there. Try to get a little pun in. Sorry. But he kind of had 4 steps or 4 pillars that he talked about. And that's the way I've been able to frame those conversations with patients going forward after that is, debridement. So getting rid of the dead tissue, utilizing appropriate antibiotics, making sure there's adequate blood flow, and then kind of the catch-all pillar or step, the good wound healing environment, just meaning offloading, tobacco cessation, glucose control, all those kinds of things. So it just really gave me like an organized way to talk with patients about it. So I think that's been really good. Another one that I really liked from that episode, which we had a lot of fun with, I know when we produced it, was even one of our graphics, I think. But I still feel that all the time when you get these patients admitted to the hospital, that somebody wants that wound swab from that foot. And I just felt like it was worth saying again that, those results are probably not going to correlate with what's going on necessarily and the pathogen. So really trying to make an effort to get the tissue culture at time of debridement. So swat the swab, which is what we went with. And I kind of like that. So I still use it on rounds. Gets occasional laugh when I say swat the swab.
I mean, that really is the highlight, I have to say.
Yeah, absolutely. Another one that I thought was just giving myself more confidence to hold antibiotics in the right clinical situation for those patients with diabetic foot infections. I feel like our instinct a lot of times is, okay, we're admitting diabetic foot infection, let's start antibiotics. But after doing that episode and kind of thinking through it, with the right clinical stability of the patient, let's say we have a known plan for debridement with retrieval of cultures, sometimes it's really reasonable to hold empiric antibiotics up front. So it's kind of helped me build confidence and kind of teach that to the residents as well. So I think that's been good.
Yeah. And I'm going to add one thing before you go on. The other one that when I was looking back at that episode that I just found interesting was when Dr. Webster was talking about the empiric antibiotic coverage, was that pretty much most antibiograms across the country is going to require MRSA coverage, but was less confident in all of the being aggressive with the double pseudomonal coverage. And I think that's helped frame when I do need to start them too, what am I really prioritizing?
Absolutely. Yep, that was great. And then even with the anaerobic coverage there too, even, thinking about those in the right clinical situations, when to
I just
hold
remember
off.
being very grateful that he told me I didn't have to start micafungin on everybody. So
Yes, there you go. My last one from that episode that I picked was just, thinking about advanced imaging and just imaging in general for those patients with the diabetic foot infections. Pretty much all those patients, when you're admitting them, probably need an X-ray. I think we kind of established that during the episode. And then whether or not going on to MRI really took into account a lot of different factors. And we kind of discussed those during the episode, but, sometimes relying on, laboratory data, like maybe ESR, maybe like clinical exam, like probe to bone, and just realizing the limitations of X-ray, that sensitivity is just limited because it can lag behind by weeks. So just X-ray up front, and then kind of taking a pause and really thinking about need for MRI after that.
Yeah, and I think the other thing that I took away from that was like, you're getting the MRI so you can get like diagnostic information from it. But I think the other thing we talked about during that episode was like how like probe to bone, like as a test, would also be like diagnostic. And the part that I think was like interesting to me is I think he talked a lot about like how it is dependent on the practitioner's experience for the like accuracy to probe to bone, which at least then like makes me feel more confident that like that's not necessarily me who should be probing to bone. Like that is making sure I have the right person to like assess that. And that can sometimes get you your diagnostic information faster than the MRI too.
Absolutely. So those are some of the highlights I took away. I think, again, I'll put a plug in for it. I think the whole episode's great, but those are some of the things that I've used, especially every time I'm at the VA or something like that.
So from holding antibiotics appropriately to probably giving them to just about everybody, let's talk about our sepsis episode, Caroline, with our guest, Dr. Moline King. You did our wonderful graphics as per usual. I think me and Meredith produced it. But yeah, just give us some pearls from that episode that we did.
Yes, definitely antibiotics for all, and we'll get to that. But I think some of the beginning pearls that were really helpful were sussing out how we're diagnosing sepsis at the bedside and in the context of really like a rapid response. There's all these acronyms we have for screening. We talked about SIRS and how we all got really comfortable with that, but it turns out it's not super specific to sepsis. We have a lot of hospitalized patients that might score positive on SIRS, but not be having this dysregulated immune response to infection causing end organ damage, or really this sepsis response. So then roll around to the next guidelines in 2016, and we came out with QSOFA. We thought this was going to be excellent, and it is, but it's maybe not as sensitive as we would like. So there's a couple other scoring tools like News and Muse that are maybe going to be a little bit more sensitive, but they're a little bit clunky to use at the bedside. So we're left really with QSOFA being our best screening tool, especially when we're in a rapid and need just a really quick screening tool to use with 3 variables. So I thought that was a great pearl and nuanced discussion about how we're really defining this.
MedCalc really can't help you when you need like 800 pieces of data. I mean, it can, but you need all those data. So I agree.
Exactly. Just being able to gauge based on a basic physical exam and vitals is super helpful when you're at the bedside. We then moved into some really helpful management pearls, again, in the context of a rapid response. We talked about how antibiotics should be given really within the first hour of identifying sepsis. And your fluids you can give within the first 3 hours. But talked about, and I thought this was really interesting, how POCUS should be involved in making some of these decisions. And POCUS might be helpful with identifying like what kind of shock is going on. Is this sepsis or something else? But we did talk about how a POCUS exam shouldn't be used to guide your fluid resuscitation or to assess if somebody's responded adequately to fluids, which I think is helpful, especially as more and more of us are using POCUS, especially in these rapid situations. And lastly, she brought up this total fear point, I think, for everybody of what happens if the fluids don't work and if you need pressors. And I think she definitely calmed some of our fears that peripheral pressors are safe. And actually, there is some good data for that. We probably don't want to be giving this in a really peripheral IV, like in the hand. But if you're at or above the AC is, there is data to show that that's safe as well. So we have that pocket in our toolkit as well. The last pearl I thought was really helpful to remind us is that during a rapid, is a really hectic situation, this is not the time to be having your goals of care conversation. So just a gentle reminder to be having these a lot earlier in the admission, so we can have those goals established before things get a little bit crazier.
Yeah, I thought the most wild part of this whole episode was the pressers. I mean, I think we talked about a lot of other things, but I still, even when I was going back and re-listening to this a couple of times, I was like, oh my God, I can't believe we talked about giving the pressers. And I think even in the episode, I was like, I'm still calling you because I'm going to be really nervous if I have to do this. But to the point that you just made that kind of above the AC, probably okay. I thought the other part that was interesting was if all you have is an IO, then that's what you have to give. And I think that, the premise of the conversation is really that you have a patient in front of you who is sick and you are thinking of it as an ICU situation, like you are throwing the kitchen sink at them. And so that is why, doing something rather than nothing is the better option, instead of kind of being paralyzed by overthinking, as I think many medicine doctors do, because they got heart failure and someone has kidney disease and all these other things that are going to be impacted, and it's really easy to start going down every rabbit hole of the patient's history, but just kind of being okay with hey, their basic vital sign of their blood pressure is not perfusing anything, and so you need to do something to get their blood pressure up. I think is kind of makes sense in the long run.
No, I mean, I think I remember saying at the time, I feel like I was taught that if you even thought about a peripheral pressor, you're going to rot off someone's limb. So that was really helpful.
Okay. So I think that's a great summary of those first two episodes. And for, for those diehards out there, I know those are technically not 2024 episodes, but we really enjoyed them and we didn't get to recap them last year. So we included them in this one. So forgive us. But I think the first kind of hospital medicine episode of this year was actually done by Matt and Paul, while visiting Emory. They did Sickle Cell Crisis for the inpatients, with Yumi Shin as the guest. And my favorite part of re-listening to this episode was listening to Matt retell his Target story. And for those of you who don't remember that one, highly recommend going back and listening. But my main takeaways from this episode was really the analgesia. I feel like that was why this episode exists. I think that is one of the major areas of discomfort for the providers. So just having really kind of clear guidance on 60 minutes to door to analgesia, and then reassessing within 60 minutes and really doing your best to get pain crises under control. And then I really enjoyed how Dr. Shin went through everything for framing the opiate management. So if someone is on outpatient basal opiates, then keep them on that and then use the PCA for the bolus dosing. I think this is just a much easier way to think about it and to help titrate during the acute pain crisis that they're experiencing. And then I also like that she emphasized the non-opiate therapies, like ketorolac and Tylenol scheduled, especially for those first 48 to 72 hours, and to be generous with even topical diclofenac and lidocaine patches, which I often counsel patients hey, I don't think this is going to get rid of the pain, but I think it may help cut the edge a little bit. And I think that that's kind of the premise for recommending that here. And then I also deeply loved the conversation they had about thinking a little bit about the concept of tolerance in this patient population versus really being worried about opiate misuse. That this population, while the stigma is such that there is a higher incidence of opiate misuse, that's really not true. And that what you are watching and what you're seeing is probably tolerance to the therapies that they're on as an outpatient, and that your discomfort with seeing some of that milliequivalence does not necessarily mean that they are misusing it. And I think that's just an important reminder to many of us who see that stigma day in and day out.
The PCA part, I think it blows my mind every time I hear more about how PCAs are actually more effective and shorten stays and all that sort of thing. So I think anytime I hear something, and then of course in this sort of tricky sickle cell management, and then as someone who had to work really hard in her career to fight stigmas in my brain. Having those kind of conversations is really important about the bias that we have. And I think I really appreciated the fact that they took the time to have that. So, but speaking of bias, Meredith, you've got more for us.
Yeah, it's my jam. Uh, so I think jumping to episode 446, our Psychiatry Primer for the Hospitalist, which we also recorded at SHM this year with Dr. Aaron Gluth. The whole kind of base for the episode is really that our patients with severe mental illness experience, a 10 to 20 year shorter life expectancy than the general population. And this is actually attributable mostly to like physical life limiting illnesses such as cardiovascular disease and metabolic diseases, which Dr. Gluth reminded us is mostly related to the medications that they're having to be on for like their psychiatric illnesses as well. And that this is something that we should be a little bit more mindful of as their medicine doctors. So I think that that was like a big take home point from the episode. And then I think that the other things that I just wanted to highlight is, and what I've actually started using in my own practice is for delirium, not always checking just like A and O, but a little bit more on their ability to concentrate like on a test. So like world backwards, serial sevens, whatever it may be. And I have noticed like that has been much more helpful many a times, especially because like everyone does A and O, and so you don't know if someone had just done it with the patient and therefore they're scoring higher. So that, and then I think the other thing that I just would probably highlight from this is agitation, like gearing your like chemical restraints to the patient in front of you. So the young 25-year-old that might have co-substance use issues but is otherwise healthy is going to require something very different than your wandering patient with underlying dementia with 8 other comorbidities. I think that while obvious, sometimes in the heat of a situation that is difficult to remember, especially when it's requiring a lot of resources from staffing to handle the situation. And then I think that the other like big thing that we talked about was thinking a little bit about like the famed reversible workup and what is actually needed. And so you can listen to the episode. I mean, we talked a little bit about like folate's probably not necessary, but like TSH, HIV, syphilis testing, all important because these are like maybe not, you're not going to find a lot of it, but if you do, these are reversible things that could treat the underlying condition. But one of the things that I found interesting from the episode was actually the comments about vitamin D. I felt like when I got to my current job, everyone from psych would tell us to check vitamin D, and I was doing it, but I didn't really understand why. And Dr. Gluth was saying that vitamin D deficiency is comorbid with some of the anti-epileptic drugs and mood stabilizers that these patients are on, and so that there is still value in checking it. Because I also have this theory that we check way too much vitamin D, but at least I was like, I can follow that logic then. And with that said, I haven't actually found like treating their vitamin D deficiency has changed anyone's life, but I'm still hoping.
Yeah.
And then the last thing, I guess, going back to the mortality gap for a second is just with that in like your frame of reference, like, and thinking about your reversible workup, like maybe considering adding in your A1Cs and lipid panels to that. So I don't know, Monee, if you had anything else to add.
I think the biggest take home point for me was just really remembering to think about what the right thing is for the patient in that moment in time and making sure you have a clear and open conversation with your consulting colleagues to make sure everyone is on the same page. And again, like you said, it's a resource issue. It's like we all want to take care of patients. We all want to do what's right for them. And like sometimes the milieu unit doesn't have the resources we need to take care of their medical illnesses. And truthfully, if you really want another reason to listen to this really great episode, it would be to hear about Dr. Aaron Gluth's undying love for Nicolas Cage. So just if you needed any more, then there you go. From one fan to another, this next episode, I am not kidding you. I have had the most residents, students, etc., come to me and tell me how much they enjoyed this episode for the sheer reason of our guest, Dr. Dan Dressler. For those of you that don't remember, it is our Syncope episode, another live SHM episode produced by our colleague, Dr. Emi Akamoto. Caroline, I think you were there live watching it happen. So watching us be delirious on jet lag, tell us a little bit what you remember from the episode.
I was live in the flesh, yes. And I think there were some really great pearls about how syncope is one of those diagnoses that history and exam just can't be replaced. It's essential to making both your low risk and your high risk etiology diagnoses. And really just to reiterate that a lot of those low risk etiologies like vasovagal syncope or orthostatic are completely diagnosed by history and exam. So to make sure that you and your learners are doing a really thorough job with that. But of course, we're always worried about the higher risk causes like cardiac syncope. And Dr. Dressler talked about how the Canadian syncope risk score is a really helpful tool for us to be using to screen for these patients that might need a more thorough workup. The last thing on the history pearls was that, there's lots of mimickers of syncope. And I think one of the ones that we worry about often is seizure. And some of the pearls that'll help you distinguish between those two is that both can actually have urinary incontinence. But some special things about syncope are that if there is some jerking movements, they're often more myoclonic in nature. They're shorter, like less than 10 seconds, and the patient's not really postictal. Contrast that with syncope, where the movements are more tonic-clonic. They're often a lot longer, like more than 30 seconds. The patient will be postictal. And then something with a history element with a really good positive predictive value he talked about was the lateral tongue biting. So to not forget to ask about that on your history. But, we're hospitalists. We always think about the further diagnostic workup that we might need to do if our history doesn't completely close that book of what we think is going on. So we talked about some of the further, more advanced diagnostics and when to pursue those. So Dr. Dressler's expert opinion on pulmonary embolism was that if there's no obvious low-risk etiology that you identify, he does get a D-dimer to screen these patients. And we had a really nuanced discussion about the PESIT trial and some of the subsequent literature and about how to interpret that as hospitalists. So I thought that was really helpful. And then when to really investigate either a really in-depth neuro workup or cardiac workup. And he guided us that, unless there's a really compelling history or an exam finding that shows a neurodeficit for a stroke or a really compelling history for a seizure, we don't need to really uncover or, turn over every rock as far as a neuro workup. And same thing with a cardiac workup, specifically with an echocardiogram, unless there's, a really compelling history with palpitations or you hear a heart murmur on exam or have an abnormal EKG, we really don't need to be getting echoes on everyone. So I agree, Monee. Even for junior faculty out there, this was just such a succinct way to move through syncope. I loved it.
I also, when I was listening to this, do you ever hear someone say something and it's so obvious that you're like, I shouldn't actually be amazed by this fact, but then you are? That's how I felt like listening to it again and hearing him say like, a drop in blood pressure, but no change in their heart rates is like autonomic dysfunction. It was so obvious, but until he said it, I just hadn't thought about it like bedside with patients.
Mind blown after mind blown. I guess it's fitting that you ended talking a little bit about whether or not we need echoes, because we're going to talk a little bit about ACS. Our most recent 2 episodes apart, it was a twofer because it was just such a banger. We needed to break it up into 2. So ACS with Dr. Sanjeev Francis, it was a great conversation, and he really helped me clarify some things that I had clearly muddled together in my brain. So the first was not as muddled as is just like enlightening, and I had literally never thought to do this, but apparently auscultating your carotid, and if you hear like a bruit, can be indicative of atherosclerotic disease and could point you in the direction of ACS in someone that has, presenting symptoms suggestive of it. I think perhaps as somebody who works at a hospital that does not yet have the 5th generation high sensitivity troponin, it was really helpful to clarify, one of the most important things to keep in mind about it is that it detects lower circulating levels than any of our other tests we've had in the past. So even if something is below the threshold for what's considered like positive, you still get a number, and trending that can be helpful. In addition to sort of having that lower threshold, I think the other thing that was important to keep in mind is you have a test that you can use in shorter intervals. So back in my day, it was like 6 to 8 hours that we had to wait. I think RJ's shaking his head because we're both
Absolutely. I remember.
similarly old. Yep. But now, with these new tests, it's 1 and 3 hours or 2 and 4 hours. And I think that's just been kind of groundbreaking, I think, for throughput and all the things that we talk about and sort of moving patients through the healthcare system. So I think if I think and sit really hard and think about EKG, some of these things would be a little bit more intuitive, but alas, I do not. ST elevations in the lead AVR or ST depressions in the other leads can be highly suspicious for atherosclerosis. And then I think the moment where I was definitely like having a hard time formulating the question because I had read so many guidelines that I didn't know what it was the existence or potentially lack thereof of unstable angina. And the answer is yes, it does exist. It's on kind of thinking about ACS on a spectrum. And kind of the reason there's a little bit of confusion was that there's these 2020 chest pain guidelines that kind of help you decide if someone should be worked up on that spectrum versus not. And using something like the heart score can help you funnel someone into that spectrum versus not. But unstable angina is still apparently a thing. So that was good to hear. Coronary CTs are an interesting thing that I think I've had to grow a little bit more comfortable with time. But one of the pearls that I learned specifically is these can now assess coronary circulation, and it's something called the FFR, the fractional flow reserve. That had previously been reserved only for catheterization. So that's really cool that we're able to do that without putting someone through the full procedure. And the warranty that you get on a coronary CT, if it's stone cold normal, and he was very clear that it had to be completely normal, is 2 years. Other tests, if they're stone cold normal, he said roughly a year. But honestly, if you're talking to the patient and the story's good, like anything's kind of up for discussion. But those are kind of some rules of thumb that he had. And then last but not least, cardiac rehab is highly effective. Pretty much anyone and everyone you can get into cardiac rehab with these medical problems should definitely get it if they can, which I think we all kind of know, but like maybe we're not as mindful about doing,
Yeah, I definitely don't think about it. The other part of that episode that I think was helpful, going kind of back to the CTAs and stuff, was when they are coming in as like NSTEMI or non-ST elevation ACS, whichever version we want to use, classifying people into high risk versus very high risk to kind of reorient the emergent need for the catheterization. I thought it was helpful to have the conversation to clarify those two things. I still in real life find that confusing, like how I am supposed to really be like, this is very high risk. Hint, hint, nudge, nudge. Open the cath lab on a Saturday when you're still resource limited.
Yeah.
Because I do think that that's kind of the underlying set of questions that kind of exist in real life.
Yeah, I think that part of the discussion was interesting about this, 24-hour thing for NSTEMI, like how hard and fast is that? And what we learned is like, what are your resources?
Yeah.
And then, if it's progressing and you're seeing dynamic EKG changes, obviously that's a different conversation. But certainly even a renowned cardiologist can't really give us I guess there never really is a firm for anything. But that was definitely an interesting part of the conversation that, frankly, I was hoping we'd get a little bit more oomph so that we could.
I wanted more oomph in my life.
I really did too. So I don't know.
Unfortunately, it wasn't there.
So I think that actually brings us to the end of our recap, which has been a really good ride. It was great to have RJ and Caroline on with us at the same time. Those opportunities are few and far between, so we have to be grateful for them when we can. Meredith, you want to start with some reflections
from the year?
From the year,
I'd love to. So, first and foremost, I'm very thankful for this whirlwind opportunity to be part of the show. I really, in thinking about this episode and doing this first recap, can't believe we've been doing this for 3 years already, but we have, and it's been a lot of fun, and been a lot of fun to get to do it with people that I respect a lot and are fun, and just have really enjoyed working with the whole team. The listeners, you guys have always tuned in, and you have offered great ideas for shows and suggestions on how to make things better, and just eternally grateful for that feedback all the time. And I think that the other opportunity that has kind of come from this has been our experiences at SHM Converge the last 2 years. It's been a great way to, frankly, meet a lot of people, but also kind of orchestrate what we think is kind of the most important things for the hospitalist, as we've kind of been working on this mini series, I guess, ongoing mini series. I don't even know what to call it, but of the hospital medicine shows. And so we will be back at Converge 25. So if you're there, come find us. We'd love to meet you in person. And I guess in summary, just really thankful to everything. And Monee and I are really a small part of a much larger operation, and just been a real pleasure to work with everyone.
Yeah, I don't have a lot to add, actually. It's bonkers to think it's been 3 years that we've been working on these episodes. A sub-series instead of a mini-series.
Yeah, that's probably the better.
Yeah, we're going to call it a sub-series. Want to express my gratitude for the entire Curb crew, both the listeners and the team members. They are the MVPs because they do the lion's share of the work, even though you're hearing our voices every month. Caroline and RJ, you have added the best flavors to this mix. I can't even tell you how wonderful it's been to have the help, but also just your energy and your creativity and your thoughtfulness with everything that you do. Meredith, I'm glad I was able to teach you the definition of effervescent this year. It's been 3 years of me using it, so glad we got there somewhere at some point.
That did happen.
Happy to provide a vocabulary lesson at any time.
Mm-hmm.
And really just to work on all of the things with you. And again, just like Meredith said, it was really great to meet some listeners at SHM last year and the year before. And I really can't meet more of you in person next year. So hope to see you there. And with that...
This has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
Yummy.
Still hungry for more?
Yep.
Join our Patreon and get all episodes ad-free, plus twice monthly bonus episodes at patreon.com/Curbsiders. You can find show notes at thecurbsiders.com and sign up for our mailing list to get our weekly show notes in your inbox, including our Curbsiders Digest, recapping the latest practice-changing articles, guidelines, and news in internal medicine.
And on the Curbsiders, we're committed to high value of practice-changing knowledge. And to do that, we need your feedback. So please subscribe, rate, and review the show on YouTube, Spotify, or Apple Podcasts, or email us at askcurbsiders@gmail.com. A special thanks to our co-writers and producers for this episode, Caroline and RJ, and to the whole Curbsiders team. Technical production was provided by Podpace. Elizabeth Proto runs our social media, and Stuart Brigham composed our theme music. Until next time in 2025, I've been Monee and
And as always, I've been Meredith Trubitt. Thank you and good night.